everyone. I'm Lexi. I'm in a second year. Today I'm going to talk about ultrasound-guided identification of fractures. I know Silverberg's really excited about this. I just want to thank the Small Talk team, Dr. Chu, Dr. Kopchak, Dr. Turner, and then our lovely ultrasound fellows, Dr. Hannison, Dr. Lee, and then also Dr. Drenes for helping me put this presentation together. So let's start with a case. So we have a 12-year-old left-hand dominant male that's presenting with left wrist and forearm pain and swelling after running into a wall, and he used his outstretched left hand to brace the impact. And this all happened while he was at wrestling practice. When he presented, his exam was notable for tenderness and swelling over the wrist, over the distal radius. He had decreased range of motion due to pain, but there was no obvious deformity. So we got some X-rays of the hand, the wrist, and the forearm. These are just the wrist and the forearm, just to simplify it. So as you can see, there's nothing that really jumps out to you right away as being abnormal. Here's some extra views of both of them. And then the final interpretation of these X-rays was no acute fracture dislocation. While we were looking at the images ourselves, because you should always do that, we came across this view here. Yeah, that looked a little bit irregular in this region. It's kind of hazy. It's not as smooth as the other side of the radius. So we called the radiologist and asked them to go over it. They weren't too concerned about it. So Dr. Drenes actually went up to the radiology attending's office and talked to him about it. He wasn't too concerned. He thought it was just an extension of the growth plate. And especially because it was just on this one view, he stuck by that there was no acute fracture. So we reevaluated the patient after ice, analgesics. He was still really tender over that point, and especially over this point of concern on the X-ray. So we did an ultrasound of the arm. As you can see, the left picture is the longitudinal view of the radius, and you can see that there's a disruption in the cortex. And then the right is a still version of that to show the very obvious irregularity that was on that was the point that we were concerned about on his exam and also on the X-ray. And then because you should always, this was the transverse view on the right, just for completion's sake. So you can also see the irregularity in the cortex there as well. So we also imaged the unaffected arm, which you should always do just to compare to make sure there's no abnormalities in the anatomy of the patient that could be leading you to believe that there's pathology there. And as you can see, the cortex is nice and smooth. There's no disruption or irregularity in either view. So today I'm going to talk about using ultrasound to diagnose long bone fractures. I'm going to specifically talk about the indications of that, the data regarding ultrasound use, and then teach you how to do it as well. So usually when patients present after traumatic injury, and especially in patients like this with an obvious deformity, the first thing that we're going to get is an X-ray, and that's the gold standard for diagnosing fractures. X-rays are generally safe. They're quick to get. They have low exposure to radiation, and they can give a lot of information really quickly. If you have any concern on an X-ray or a concern about a patient and the X-ray doesn't really support your suspicion, CT can also be used as well. That has higher levels of radiation. It's time consuming, not as easy to get a lot of the time. And then MRI is also another method, but as we are very well aware, MRIs are really, really hard to get in the emergency room. They're expensive. And in the case of pediatric populations, we usually have to OBS them because it takes so long to get it. So ultrasound is really useful to give you a lot of information really quickly. It's safe, there's no radiation, and it's pretty easy to do. And then it also allows you to examine the area of interest in many different planes, whereas an X-ray is just a static image. It depends on the view, especially the quality of the X-ray produced by the technician as well. So to use ultrasound, usually you use it when you have a high clinical suspicion of a fracture, and then your X-rays don't really support that suspicion. Happens a lot in cases of like scaphoid fractures where a lot of the time you don't really see an irregularity at first and you have to often splint the patient and tell them to come back for repeat imaging. So an advantage of using ultrasound is you can take a look real quick and see if there's any abnormality in the cortex, and then tell the patient, you know, really emphasize that they need to follow up with ortho because there is a fracture versus coming back. And then sometimes they're just lost to follow up and they don't come back, and then the fracture doesn't heal correctly. It can also help narrow your differential. So in the case of like supracondylar fractures and nursemaid's elbow, a lot of the time these patients present really similarly, but the treatment is very different. So you definitely don't want to try to reduce supracondylar fracture like you would a nursemaid's elbow. Can also help you identify hemarthrosis in joint spaces and hematoma that develops in traumatic injuries. So looking at the literature behind using ultrasound, I'm sure you recognize some of the authors of this study, Dr. Mehta, Dr. Palladino, and Dr. Sinnert. They did a systematic review that examined the accuracy of using ultrasound in combination with history and physical exam techniques. They did a database search and found 8 studies that were retrospective and prospective observational studies. This included patients that presented with suspected extremity fractures. And they had other studies that they looked at that identified fractures just with history and physical exam techniques. For the ultrasound studies, they used X-ray and then also ultrasounds that were done by EM physicians. And the quality of the study was analyzed by using the QuadS2 guidelines that looked for any potential bias and then the applicability to our practice. So the sensitivity of ultrasound was found to be anywhere from 83 to 100%. The specificity is 73 to 100%, with a positive likelihood ratio of 3.235 to 56, and then a negative likelihood ratio of 0.034 to 0.2. So what these results tell us is that in the case of the likelihood ratios, a negative ultrasound has the ability to rule out a fracture, but a positive ultrasound has much more variability and it depends on the location. Some of the limitations of this study is that the majority of the ultrasound studies focus mostly on pediatric patients. So that has limitations in how it can be applicable to our adult patients, specifically our elderly patients who have maybe changes in their bone composition from osteoporosis. And then also, any fracture near the joint line really complicated its ability to be diagnosed accurately as well. But they did find in the pediatric population that ultrasound may be more superior to X-ray when detecting subtle fractures like Salter-Harris 1, buccal fractures, and scaphoid fractures. Another study that also looked at the accuracy of using ultrasound compared to X-ray analyzed 200 patients that presented with suspected long bone fractures. And they had 2 ER docs that were performing in the study. One did the ultrasound and the other interpreted the X-ray results. And they both were double blinded to each other's results. So as you can see, the sensitivity and specificity is really good from the results of this study, 99, 93%. And the positive predictive value was 93% and negative predictive value of 99%. So similar to the prior study, although the sensitivity and specificity is pretty high, there was still limitations in its ability to be diagnosed when it was involving the joint line at all. This study was interesting too because it showed that ultrasound was better at diagnosing certain fractures more than others. So like it could diagnose 100% of fissure type fractures and full separation type fractures, but then only 67% of the spiral fractures and 75% of avulsion type fractures. So how do you do this? So you're going to need your linear probe. This probe is the highest, provides higher frequency, which allows good resolution for superficial structures. You're going to use a lot of gel for this as well, but an alternative technique is the water bath technique. So if you, especially in like the hands and the feet where you can easily submerge in like a small bin of water like this, it allows you to produce good quality images without having to like actually press on the bone and cause pain for the patient, which could limit your exam. And then just for reference here, so you're going to use 2 views and you scan along the the axis of the bone in both a longitudinal and transverse view, and this demonstrates both of those. And you're going to start proximal from the fracture and then just keep going distally.
This is another bit of ultrasound with Z. This time, can ultrasound improve the care of a distal radius fracture? Ultrasound can be useful in the diagnosis and management of fractures. You can quite easily find the fracture, guide the hematoma block, and confirm the reduction. Here we will focus on a very common fracture, the distal radius fracture. It looks like this on the patient, like this on an X-ray, and like this on ultrasound. Notice the very distinct disruption in the bone. To perform the ultrasound, start at a distance from the fracture. Find the cortex of the bone, which is bright white, strongly echogenic with shadowing behind it. Here is another example of bone cortex. Track along the bone towards the fracture, which will be seen quite clearly whether it is subtle or substantial. After finding the fracture, align it in the center of your field. Then mark this with a pen on the patient's skin. Make the mark a couple centimeters away from where you will be sterilizing and injecting. Perform the hematoma block in standard fashion with your needle entering obliquely into the fracture site. Perform your reduction in the standard manner.
Sorry, that goes more into the blocks. I just wanted you to see the technique for diagnosing the fracture. So as I mentioned before, another good use for ultrasound is to distinguish between a supracondylar fracture and a nursemaid's elbow. So just to orient you here, I don't know if my mouse is working. So this part here is the humerus, and then that divot there is the olecranon fossa, and then the bone right there is the ulna, and then up that muscle there is the tricep. So as you can see in the picture on the right, there is elevation of the fat pad within the olecranon fossa, and that indicates lipohemarthrosis, which is suggestive of an occult fracture. So in the picture on the left, seeing that fat pad, there's a nice smooth line between the humerus and the ulna with no extension outside of it. That's completely normal. It's the extension of the fat pad kind of pushing the tricep up out of the olecranon fossa that indicates an occult fracture there. So this is really helpful to prevent you from potentially trying to reduce a fracture like this instead, like when you think it's a nursemaid's elbow. So limitations for ultrasound, the main limitation is pain. So in putting direct pressure on a really painful extremity injury and it being a fracture can also prevent you from getting a good exam. The water bath is an alternative technique to help mitigate that. But obviously that's limited on the location of the fracture. You can't put certain areas of the body into a water bath in our ER. Another limitation is the fact that it's operator dependent. So you have to be comfortable with looking at the normal anatomy to be able to identify the pathology. And then anytime the fracture involves the joint line, that seems to be an issue, both in X-ray and in ultrasound, and being able to diagnose the fracture. So later in the shift, we looked at the images again, and a new radiologist came on and addended the prior radiologist's report. And it said possible mild irregularity of the distal radial metaphysis extending to the physis on the oblique view correlate with the physical exam for a subtle Salter-Harris 2 fracture. So we consulted ortho. Ortho placed our patient in a short arm cast, as you can see here. He was discharged with analgesics and ortho follow-up. He saw ortho in the clinic. He kept the cast on for 4 weeks and then it was removed, and he tolerated that well without any complications. So in conclusion, ultrasound is sensitive and specific and useful in detecting multiple types of fractures, but it's most useful when you have a high clinical suspicion and your X-rays are not really supportive of that. And you just want to find out if there is a fracture before sending them home in a splint. And then also helpful in the cases of the supracondylar fractures in the nursemaid's elbow to distinguish between the two pathologies and to help guide treatment. This is not at all saying that we're going to abandon X-rays. I think ortho would absolutely freak out if that was the direction we're going. It's just something that you can keep in the back of your mind to help you when you're in a situation such as this one. And then it can also benefit our patients because it prevents them from potentially getting lost to follow-up. When you splint them, tell them to come back in a couple days for repeat imaging, especially in our peds populations, that usually requires the parents having to take off work. So it's common for them to not actually follow through with this, and it prevents them from not being properly managed and followed for potential fracture that we may or may not have seen when they were in the ED. So these are my references. Thank you. Any questions?